This video is going to be on chromosomal abnormalities and how they present. Now, chromosomal abnormalities can occur for a variety of reasons. The main reasons we're going to talk about today are non-disjunction and microdeletion. To understand non-disjunction, let's first review our meiosis. So here you have a cell, it goes through meiosis 1, where it splits up, and then finally meiosis 2, where the chromosomes split again. Something like that. And after which, if we pretend this is the egg, then a haploid sperm will go into the egg, make your diploid. And that is normal meiosis. Now in non-disjunction, you can have a problem with meiosis, either in meiosis 1 or in meiosis 2. Let's see what happens if there's a problem in meiosis 1. So this is meiosis 1 problem. So in meiosis 1, if there's a problem in non-disjunction in meiosis 1, then you don't get that split. So it stays stuck here. That means this cell will be empty. And this cell will go into meiosis 2 and make nothing. This cell will go into meiosis 2, split like that. And so if a haploid sperm comes in, it'll enter the cell and make a haploid, or because we're talking about sex chromosomes, monosomy, or is missing a chromosome. Monosomies are seen in things like Turner's. Okay? If a haploid sperm comes in here, it's going to see that 2 chromosomes. It's going to enter the egg and make trisomies. And trisomies, you can have it in any chromosome, but the main ones we talk about are 13, 18, and 21, or Patau, Edwards, and Down syndrome. A great memory aid is 13 is an age where usually you hit puberty or in puberty. So puberty, P for puberty, P for Patau. 18 is when we can vote or elect somebody. So 18 elect, E for elect, E for Edward. And then 21, that's when we can drink. So D for drink or D for down. So those are your trisomies. And that is what can occur in non-disjunction of meiosis 1. In non-disjunction of meiosis 1, there's not a good outcome. You either have trisomy or you have monosomy. Let's see, so let's just write no good outcome. In a meiosis 2 non-disjunction, let's see if we can get a good outcome. So meiosis 2 non-disjunction, we'll start with our egg, our normal egg. That goes through meiosis 1 normally, because again, we're talking about meiosis 2 problem, so it goes through meiosis 1 normally. And then here's the problem. Here in meiosis 2 lies the problem. So let's just say this egg splits up normally. However, this egg has a problem in meiosis 2. It doesn't disjoint, there's non-disjunction. And so you have something like this where it doesn't split up. And a haploid sperm comes in, fertilizes this egg, and this is actually a diploid. That's normal. All right there. However, if a haploid sperm comes in, fertilizes this empty egg, it'll be a monosomy. If it fertilizes this egg, that's a trisomy. So in meiosis 2, you can have your myosomies, you can have your trisomies, but you can also have a possibility of it being a normal outcome. So that's meiosis 1 non-disjunction, that's meiosis 2 non-disjunction. And we're going to continue our videos talking about trisomies, mainly these ones. We'll start with the most famous and the most common trisomy 21, also known as Down syndrome. Now on the step, they don't just say Down syndrome. Instead, in the question stem, they'll give you the physical characteristic of Down syndrome, and you have to make that connection that they're talking about someone with Down syndrome. So they might just say things like, patient comes in with mental retardation, epicanthic eye folds, which is a fold in the corner of your eye. That's what gives Asian people their characteristic eyes. Epicanthic eye fold, single palmar crease. So if you look at your palm, you'll see a lot of creases. And single palmar crease is just a single crease. They used to call it simian crease, as in simian as in the monkey. They don't do that anymore. They don't do that anymore just for professional reasons. Wide space eyes, also known as, you can also have wide space eyes, also known as hypertelorism. There's a few more, like wide space, first two toes, things like that. But in general, in the step, they don't straight out say a patient has Down syndrome. They'll give you their physical characteristics, and you have to piece it together. And another thing is you have to know what Down syndrome is associated with. The chromosome 21 has hundreds of genes, and so there are a lot of things it controls, a lot of things that it helps develop. So if you have an abnormality in that, you can have things like CVS abnormalities, GIT abnormalities like Hirschsprung's, or duodenal-atresia. You can have leukemia, which is a big one that you need to know, especially ALL and AML. We'll talk about that a little more in our heme block. And Alzheimer's, which again is another big one, which we'll talk about in our neuro block, but know the proteins that are associated with Alzheimer's are also found in chromosome 21. So those are the big ones. Step questions synthesize all this information. We'll talk about a patient and give you their physical characteristics so you know they're talking about Down syndrome. Then ask what problems that you might see, and they'll start listing problems. Look for CVS abnormalities, Hirschsprung's, leukemia, Alzheimer's, etc. Sometimes it's not that simple. Sometimes they want you to take it one step further. So let's take Hirschsprung's, for example. Instead of saying Hirschsprung's, they might say failure to pass meconium, aka they can't poo because they have Hirschsprung's. Or in CVS abnormalities, they might just say differential cyanosis. They're basically saying CVS abnormality, etc. So know how to identify it, know what it's associated with, and then how to take it one step further if need be. That's Down syndrome. Most common chromosomal abnormality. Also, as you increase in maternal age of pregnancy, so if you're 40 and you get pregnant, you have increased risk of Down syndrome. I'll just write increases with maternal age. Now the question here is, can you have Down syndrome without having trisomy 21? Can you have Down syndrome with a normal amount of chromosomes? Yes, you can. And there are two ways we can do that. One is via Robertsonian translocation, and the other is via mosaicism. We talked about mosaicism and how you can have an extra genotype. We won't talk about that again. Robertsonian translocation, a little bit more complex. Robertsonian translocation happens on certain chromosomes that are acrocentric. That means if we have a normal chromosome that looks like this, in the middle there's a centromere, acrocentric chromosomes look like this, where the centromere is on one end. And that makes it very easy to break off. And these acrocentric chromosomes include things like 13 and 14 and 21. And when these break off, then this large piece can fuse with another chromosome. So let's just say, for example, this is chromosome 14 and this is chromosome 21. If these two large pieces break off, they can fuse together and look like this. The large pieces fall off, fuse together. The small pieces, they can also fuse together, or sometimes they can get lost altogether. So we'll just say large piece or arm, large piece can fall off and fuse. Let me give you another example just to reiterate what I said. So if dad has a normal chromosome 21, a normal chromosome 21, a normal chromosome 14, normal chromosome 14, and mom has chromosome 21, chromosome 14, normal, but has a Robertsonian translocated 1421. And their offspring inherits a normal chromosome 21 from mom, a normal chromosome 21 from dad, so two normal chromosome 21s, inherits a normal 14 chromosome from dad, and inherits this from their mom. So on karyotyping, you have a normal amount of chromosomes, but you have an extra 21 because of that fused piece. That is Robertsonian translocation. That is something you must know. If they talk about a person that clearly has Down syndrome, but they say they have normal amount of chromosomes, they're either talking about Robertsonian translocation or mosaicism, okay? I think that's all I want to talk about on Downs. Let's move on to Patau and Edward. Patau and Edwards are a little less common, and they're also more severe. Patau is associated with things like failure of hemispheres to close. Your facial hemisphere, your cerebral hemisphere. So you'll have cleft lip or palate. Palate is a big one. P for palate, P for Patau. Hollow prosencephaly. That's when your cerebral hemispheres fail to close. And also things like poly, P for poly, dactyly. That is Patau's, Edwards. Seen with clenched hands, and they have overlapping fingers. So clenched hands with overlapping fingers. And rocker bottom feet. That's a MSK disorder where your feet are basically curved instead of flat. That's Edwards, that's Patau. Can we screen these early on in pregnancy? Sure. We do that with things like ultrasound, looking for transnuchal translucency, which is basically a piece of fluid on the back of your neck, and that fluid can collect if you have cardiac abnormalities. Classically seen in Downs, but that's somewhat non-specific. If we want to add additional tests, we can test for biomarkers during pregnancy, so things that are produced either from the mother, placenta, baby, what have you. And if those biomarkers are abnormal, we know something's not quite going right with the fetus's development. So biomarkers such as the protein PAPA, or pregnancy associated protein, and quad screen. So quad screen, quad meaning four, you're looking for 4 different proteins. One of them being alpha fetal protein, which is basically the albumin of the fetus. Beta ACG, made from your placenta. Estriol, which is an estrogen made from your fetus and your placenta. Inhibin A, which is made in your ovaries and also your placenta. So we're using all these biomarkers, using all these proteins and hormones, we can tell if these are abnormal, we're suspecting there's something wrong with their development. All right. In Edwards and in Patau, very easy. All of these markers are decreased. Something you should know, Patel is somewhat variable, but for your intents and purposes, they're decreased. And I don't suspect they'll ask it because it can be variable. That wouldn't be quite fair. But just know that for sure Edwards is decreased. Downs, you're gonna have your nucleotranslucency. You're also gonna have decreased markers, except for beta HCG and inhibin. These are going to be raised. So know that well. The memory aid that I've made up, or maybe I subconsciously copied it, which could be the case, is that high is high. So H stands for beta HCG, I stands for inhibin. So HCG and inhibin are high. Know that. So just to recap, Edwards and Patel, everything's down. Downs, everything is down except for high. That is your screening test for chromosomal abnormalities. And those are your classical trisomies. A few more chromosomal abnormalities I want to talk about, and those are due to microdeletions. The microdeletions, the first one we're going to talk about is cry of the cat, or cri-du-chat, noted for things like mental retardation, but namely a high-pitched cry that sounds kind of like a cat. And they really mean it, so if you have the chance, Google it or YouTube it, just listen to it, and it will sound very cat-like. So high-pitched cry. And you need to know it's due to a microdeletion of chromosome 5, in particular the short arm. That's all I want to talk about on that one. Very easy to identify, so they might ask instead some genetic questions, what chromosomes it's located on, etc. Or what the problem is a problem with microdeletion of the chromosome. Another microdeletion is Williams. And in Williams, you have a microdeletion of chromosome 7, in particular the long arm. And here you're going to have mental retardation, but you're also going to have characteristically elvish faces, elf-like faces. Again, Google is your friend. They'll look like an elf. And the most discerning or easy to pick up characteristic is that they're very, very sociable, very friendly to strangers. So we'll just say sociable. The last one, the one that is commonly asked, is a microdeletion in your chromosome 22, also known as 22q11 microdeletion. And this controls a myriad of things, but it particularly controls your third and fourth brachial pouch and your neural crest cells. Now your third and fourth brachial pouch are important in development of things like your parathyroid, your thymus. Your neural crest cells are important for cardiac development, so heart. And so if you have a microdeletion of your chromosome 22, you're going to have problems with these. And all that combined we just famously call the George syndrome. The George syndrome. And in the George syndrome, patients have thymic aplasia. And because they have thymic aplasia, they don't make T cells, and so they're immunocompromised. Cardiac defects due to the failed neural crest cells, and things like hypocalcemia because your parathyroid doesn't work. You can't make PTH to raise your calcium levels in your blood. That does it for chromosomal abnormalities. Hope you enjoyed the video. See you next time.